All right, everybody, it is Dr. K here, and we've got another case. Let's see what we've got. Draping's very good, no lashes. We got some viscose on the cornea, we always do that. I don't know if I mention it. We'll make our side port nice and square, parallel to the iris. If you make it kind of pointed down, it's going to leak more. Sometimes I'll even try and angle it up. A little bit of Lido with Epi, and then a good fill of viscoelastic. Usually try and get a good fluid wave across the cornea, wiggle to get those bubbles out. Then mark the cornea and make our 2.4 millimeter incision, nice and square. Thornton ring with the spikes up, and try and make a nice square incision, with just a square entry. Now 0.12 to stabilize the eye and the Utrata forceps. And we're just going to punch in, and we're going to be mindful of that mark we placed and try and get a nice five and a half millimeter. I usually have a little bit larger rhexis, 5.5 millimeter capsular rhexis. And just gonna grab and come around. I don't really care how many times I regrasp. Not in any sort of race. My biggest concern is that it looks nice and square with good coverage when we're done. And then we'll use hydrodissection and hydrodelineation to loosen up the lens. Nice fluid wave, there we go. Push down, other side, same thing, and rotate. Perfect. And then a little hydrodelineation there. Spin to do that hydrodelineation. Now, more viscoelastic into the anterior chamber to protect that endothelium. And there's bubbles. The bubbles kind of annoy me. We'll see if we get those out of there. Check the flow. Perfect. I usually use this tip is a little more aggressive than I would usually use, I think. We'll start with sculpt, do a few passes here, not too dense a lens really, and then we will use our second instrument and break that and chop it. There we go. Get out. And the nice thing about the hydrodelineation is it gives you a space to put the second instrument. You know, if you're concerned about pushing it up against the capsule, if you do a hydrodelineation, then you put it between the nucleus and the epinucleus, and you don't have to worry about that. So it gives you a little kind of potential space there to place that second instrument if there's good hydrodelineation. So you'll see it right there. Perfect. You know exactly at what level you can put that chopper safely. I do wiggle the phaco tip. You know, that's kind of mid anterior chamber. I wiggle that phaco tip to try and help with the pieces. Keep the tip, in the bag, as much in the bag as possible, really just to prevent any endothelial damage. Now that epinucleus is coming out, wiggle a little bit. Perfect. Get that last piece. Be careful not any capsule or trampolining when you do that. And then look, that air bubble, I think it kind of stayed kind of where it was before we started, which tends to mean that there's good viscoelastic feel. Obviously, if the air bubbles are moving in position while you're in the eye, then that means that they're not stuck in viscoat, and maybe there's not enough viscoat, or if they're moving slowly, maybe they've moved as the viscoat has started to come out of the eye, and you can get an idea of how much viscoelastic you still have protecting that cornea. We will do our cortical cleanup here. A little bit out of view. There we go. And then there's a few little strands on the posterior capsule, so we use a little power wash those, get rid of those. More air bubbles, and looks like we got a little subconjunctival hemorrhage there inferiorly, but that's okay. We will re-inflate with Provisc. Get in the eye. There you go. You want to make sure that capsule is filled. Obviously, you could push the capsule and the anterior capsule back, and then you don't have a good fill of the capsule with the Provisc, and then you go to put your lens in, and you could risk tearing the capsule. So make sure the Provisc or whichever viscoelastic you use gets into the capsular bag. That's almost more important than getting into the anterior chamber when you're getting ready to inject your lens. We'll do our capsular polishing, and then use a second instrument to open up the incision and inject the lens. Make sure to try and get the entrance. There you go, the lip of the injector past the incision. Sometimes when you're doing kind of wound assist, you can't do that, but in this case you can because it's a 2.4 incision with a 2.4 injector. So we will get the lens positioned and start with our INA to get rid of all of that Provisc, that cohesive viscoelastic. Go underneath the lens. Please go underneath the lens. Get all that out of there. Also, I find what sometimes happens is as you position that lens, the edge of the lens can pull some, kind of residual lens material behind it. It just kind of like grabs it from the periphery and pulls it in. So then sometimes I find having to irrigate behind the lens or go back behind the lens with the IA just to get any strands out that have gotten stuck behind the IOL. Okay, so that looks great. We've got all our viscoelastic out of there. We are going to hydrate our incisions. I hydrate the roof and the wall of the incision, and the reason for that is because if you just hydrate the roof, you're going to have a little bit of bullae if you hydrate it too much. If you hydrate the wall of the incision, that edema, that swelling is going to go away, and you're not going to see it on day one. If you hydrate the roof of the incision, especially if you do too much, you're going to have a little bullae over the surface of the incision, and I don't like that. So hydrate both, but do hydrate the roof in addition. Some people think the hydration of the walls is just too much fluid, but I don't find it to be a problem. That's it. Looks like a great case. All right. You folks have a great day. We'll see you next time.